Good afternoon, everyone. My name is Robert May. I'm the executive director here at the Kensington in Redondo Beach, California. At Kensington Senior Living, our mission is to improve and preserve the quality of life for every resident. To that end, we have built strong relationships with expert professionals who keep us current with the latest advances, care management, and treatment of conditions that affect seniors and their families. The Kensington Senior Living is a bi-coastal company. We have assisted living communities in Kensington, Maryland, White Plains, New York, Falls Church, Reston, and 3 communities here in California: Redwood City, Sierra Madre, and of course, Redondo Beach. One of the things I'd like to share with you is, and I'm very honored to introduce everything you need to know about strokes and recovery this afternoon, is there are some sobering statistics. Approximately 795,000 people suffer a stroke in the US every year. If you translate that into specifics, that means that someone's having a stroke every 40 seconds. To that end, one of the reasons why we have this wonderful seminar this afternoon is to share with you the latest research and information. Our moderator this afternoon is Neil Schwartz. And Neil Schwartz joined the Stanford Stroke Center in 2004 as a fellow in vascular neurology and has remained on the faculty since 2007. Dr. Schwartz is a national leader in neurological education and serves as the medical director for inpatient neurology, L5, at Stanford Healthcare. Please let me introduce Neil to you all.
Hey there, Robert. Thank you. Thank you so much for having me, and thanks so much to Kensington Senior Living for organizing and hosting and sponsoring what I hope is going to be a really interesting and informative hour for all of you. I want to thank my distinguished colleagues who are on the panel, who I'm going to introduce in a moment. But most importantly, I really want to thank the audience for taking the time this afternoon to spend with us and to learn about stroke. Just spending this hour, I think, is, you're really doing a lot for your own health, educating yourself, as well as for the health of people you care for. And as Robert said, stroke is unfortunately an incredibly common thing. It is one of the leading causes of death in the United States. It's the 5th leading cause, and worldwide, it's the 2nd leading cause of death. It is actually the #1 cause of adult disability. And so it's really incredibly common. Each one of you has likely been touched by stroke in some way. How do I know this? Well, about 1 out of 6 people tend to have some form of cerebrovascular disease in their lifetime. So this is really a huge problem. And I think we've made a lot of great strides in terms of stroke recognition, early treatments, which we'll talk about, some more advanced treatments, stroke prevention, and even some headways into stroke recovery. But we still really have a long way to go. But you'll hear from our panelists about some of these developments. The format here is that we are going to kind of answer a series of questions, and many of them were submitted by you guys, and we welcome more questions. You can type them into the Q&A, and we'll do the best we can to answer them. We certainly can't give any personal medical advice, so try to keep them more or less generic. It wouldn't really be safe for us to do that. So with that, one by one, I want to introduce my colleagues who are joining us today, and we have 4 really, incredible neurologists who know a lot about stroke. And first is somebody that works with us here at the Stroke Center at Stanford, and Dr. Christina Majowski Sells. And I'll let Christina say hello and say a few words about herself.
Hi there. Hi, everyone. Thanks for inviting me today. Very excited to have a chance to talk with the group. Again, my name is Christina Majalski. I'm a stroke specialist on the faculty at Stanford, lucky enough to work with Dr. Schwartz. I did my neurology training at Brown University, and then I did my stroke fellowship at Massachusetts General and Brigham and Women's in Boston. Then I landed back in the Bay Area where I'm originally from and lucky enough to work at Stanford. In addition, I'm also the medical director of the telestroke program at Stanford, and I have an interest in stroke care in women, specifically surrounding issues related to pregnancy. So again, thanks for having me.
Thank you, Dr. Majowski. And next up, I wanted to welcome Dr. Matt Edwardson.
Hi, thanks, Neil. Yeah, I'm excited to be here as well. I've been at Georgetown probably about almost 10 years now. Did my fellowship training out here at the NIH and ended up staying in the area. And I also, in addition to taking care of stroke patients, I do a lot of stroke recovery research, mostly related to motor recovery, like the arm and leg. So we touch on that a little bit later in the program, hopefully.
Okay, thank you, Dr. Edwardson. We're glad you're here. And next up, we'll welcome Dr. Lucas Restrepo.
Hello, I can't seem to make my camera work.
There you go.
There you go.
Yeah.
Well, thank you so much for inviting me. I'm excited to be here. I'm a neurologist at UCLA Medical Center in Los Angeles. My fellowship was in stroke at Hopkins not too long ago. And my residency was at Georgetown University, close to where Dr. Edwardson works. My principal interests academically are kind of the cognitive problems of stroke and dementia associated with stroke.
Okay. Thank you, Dr. Restrepo. It's really great to have you here. And then last but not least, I want to welcome Dr. Atrac Kay.
Hi, folks. I'm Dr. Kay. I work here in Fairfax, Virginia. I did my training at Duke University, and I went all the way to New Zealand to do my stroke training. These days, I do general and stroke neurology. And my specialty, or what I really like to do, is to be a good coach in the ER and in the community to get people to come to the hospital at the first sign of stroke.
Great. Well, thank you, Dr. Kay. So as you can see, we have really an awesome panel with us this afternoon who have broad experience from all over the country and indeed all over the world. And so, I think we'll jump right in and really talk about maybe just some of the basics of stroke. But, I think one of the questions I had many years ago is, where did even that word stroke come from? And some of you might be surprised to hear that it's actually a biblical reference, and it comes from being struck down by the hand of God. And you can imagine sort of in the old days, when somebody would just all of a sudden have a stroke, and strokes often, but not always, occur very suddenly with symptoms. And you could imagine somebody would lose the ability to speak correctly, or perhaps lose the ability to move one side of their body. And it was assumed that there was some sort of divine intervention there. But as over the years, of course, we know a lot more about what's actually going on inside the body, inside the brain with stroke. And so maybe we'll just, start with that. Maybe I'll ask Dr. Majowski, what is a stroke, or what are the types of strokes, and what are the types of things that could cause them?
Thank you, Neil. Yeah, stroke, very broadly defined, is when there's just an alteration of blood flow to the brain, and parts of the brain can become damaged or even die. Strokes usually come in about two flavors, ischemic and hemorrhagic. Ischemic stroke, I'll start with, is the most common type. About 85% of strokes are ischemic, and this results in a blockage of blood flow to the brain. This can be from a blood clot or even other debris such as cholesterol. Some common causes of blood clots can be a buildup of plaque, also called atherosclerosis, and it can also come from a blood clot even from the heart. You may have also heard of another term called TIA, and I wanted to mention this. This stands for transient ischemic attack, and some people may refer to it as a mini stroke. And this is really can be thought of as a temporary ischemic stroke, because usually symptoms resolve on their own on the order of minutes to hours, and they do not cause any permanent brain damage. But we should still think of this entity as a true medical emergency, as it often portends a stroke and can be a significant warning sign of a stroke. And the second flavor of stroke is hemorrhagic. And that happens about 15% of the time. This is when there's bleeding into the brain, and this can be from a leaky blood vessel or a ruptured blood vessel. Some common causes might be high blood pressure or even an aneurysm.
Right. Well, thanks. Thanks so much for that, Dr. Majowski, and that sort of overview. And so maybe I'll ask, Dr. Edwardson, what are sort of the signs or symptoms, and in medicine, we use those words, they're similar, but they're different things. Symptoms may be something that a patient experiences, whereas signs may be something that a medical professional could pick up on a neurologic exam. But so what are some of the kind of signs or symptoms of stroke? What are the types of things that patients or their loved ones should be on the lookout for? And why is it that different people have different stroke experiences?
Yeah, thanks. So I think as many as you know, strokes can affect many different parts of the brain, and the parts of the brain control different parts of the body. And so it makes sense that the signs and symptoms are incredibly variable in stroke. And that's what makes it a little bit difficult to diagnose sometimes and recognize. But the acronym we like to teach people, you may have heard it before, it's BFAST, B-E-F-A-S-T. And that stands for balance, eyes, face, arm, speech, and time. So, when somebody has a stroke, they may be off balance. You may just have difficulty walking, stumbling, leaning to one side. Your vision may go out in one eye entirely. It may go out in one half of both eyes. You may get a facial droop. Your arm may be weak. Also, this could include leg, but I don't think it fit very well with the acronym, so they left that out. Speech is often affected, so you could have either slurred speech or difficulty producing speech or garbled speech. And then time is just, we want you to get to the hospital as quickly as possible if you're experiencing any of these symptoms.
Yeah, great. Thanks, Matt. And, I was already kind of looking at some of the questions, and somebody mentioned something about, being at risk for both an ischemic type stroke and a hemorrhagic stroke. And that kind of made me think about the different types of stroke, as Dr. Majowski was mentioning, but I'd kind of open it up to any of you. Can you tell which one you're having? If you're at home and you suddenly, have stroke-like symptoms, or you notice that in a loved one, do you know whether it's an ischemic stroke or a hemorrhagic stroke?
No, that's why we recommend care to get immediately at a hospital. We oftentimes, need to do the physical evaluation. Then further, we need to do some brain imaging, because even though people have really tried to define this, there's nothing that can definitively tell us whether a stroke is due to a blockage of blood flow or due to actual bleeding. And as you can imagine, the treatments are very different.
Yeah. Okay. Thanks for that. So yeah, as I think it was alluded to before, stroke is, certainly an emergency, and it is, I think everybody on the line knows that. And, we really want to emphasize patients getting care. But, I guess I'll ask Dr. Restrepo, why do you think that some people wait to come to the hospital when they're experiencing symptoms of stroke? And, are there consequences of this? Can't you just go back to sleep and wait for it to get better?
Right. So this is a very important issue. Many times a person may not know what's happening. Some of the symptoms of stroke can be subtle and strange. Among the many symptoms of stroke, pain is not one of the most alarming ones. So many times people have a painless, sometimes subtle problem that they really don't know what to think about it or what to make of it, and many times that leads to complacency and not seeking medical advice. I'll give you an example. A person may feel like the one part of the vision is blurred, and that you may be bumping onto things, which is kind of unusual. I bet that many people have never heard of an individual who experienced such symptoms. Well, that could be the symptom of a stroke. And many times a person may say, well, you know what, I'm not going to be an alarmist. I'm just going to sit and wait, see what happens if this gets better. That can actually be a symptom of a stroke. So the problem with waiting is that the the cells of the brain are very susceptible to damage when the circulation of the brain is compromised. So there's only a few minutes when all of a sudden those cells no longer work and start dying out. So the longer one waits, the more number of cells start dying. And it's like a cascade of events. Initially, the cells don't have enough energy to work, and then they start breaking apart. Also, other parts of the brain, not just the neurons, but all other cells that kind of assist and maintain neurons, as well as the little arteries or vessels that provide circulation to the brain, also start falling apart. So the more that you wait, the more damage one gets in the brain. So that's the reason why we have this kind of concept of time is brain, meaning that the earlier that you are able to establish a diagnosis and start treating a person with stroke, the better the outcome will be. And this is a concept that is that is evident time and again after multiple studies, looking at the time of presentation to emergency room. The earlier you come to the hospital, the better off you'll be.
Yeah, thanks. Thanks, Dr. Restrepo. And yeah, I think, Dr. Majowski was mentioned this concept of a TIA, or a transient ischemic attack. And so, some patients might actually have neurologic symptoms and they go away in 30 minutes and they feel back to normal. And I'll pose it to Dr. Kay. I mean, what should patients do if the symptoms do go away? I mean, is this still something to worry about? Should they still present to an emergency room to get worked up? Is there any advantage to doing that?
Yeah, folks, what I'm hearing tonight is that we shouldn't play doctor at home. These any sudden change of function, meaning if you're able to speak, see, walk, and grab things, and you're practically doing everything normal, and even a sudden change of thinking, even as a stroke doctor, I wouldn't play doctor for myself. I want someone else to look at me and tell me there's something wrong. So no, TIAs, unfortunately, the nomenclature, I'm trying to change it on everyone that says this word mini stroke, because it downplays the importance of getting to a professional, an ER doctor, a stroke neurologist, or a general neurologist. Any of these folks, or even the nurses in the ER, are so well trained these days that they can easily pick up on the fact that there is something going on. Even though the symptoms are gone, you might perceive they're finished, but other people looking at you can easily pick those things up still. So unfortunately, just like you said, a lot of folks get these symptoms. They get super scared to understand that, wow, am I really having a stroke? And I think it's a fear-based thing. They don't get medical attention, but I highly recommend anyone who has any sudden change of function to go ahead and just come on in and let us sort it out. Leave the hard work to us and keep yourself ahead of the game is the best policy. Even for me, who sees strokes all the time, I do the same thing.
Yeah, thanks, Dr. Kay. And I guess, yeah, that the information that we might get from the workup of a TIA and the interventions we might make could really prevent that stroke from occurring within the few days or few weeks after that. So getting urgent attention, absolutely important. Okay, so patient has symptoms, they've called 911, the ambulance shows up, and patients probably don't have a lot of say in where that ambulance is going to take them. And in most communities, they will go to either what's called a primary or a comprehensive stroke center. And a comprehensive stroke center, they may be able to offer the most advanced treatments, which we'll talk about in a few minutes, catheter-based therapies. But I'll pose it to Dr. Majowski, who has mentioned that she really has an interest in telestroke. Should patients worry about where they're being brought by the EMS? Is there a chance they're going to be brought to a hospital where they aren't going to get proper stroke care?
Yeah, thank you. Thank you, Dr. Schwartz. This is a very important question that a lot of people have actually thought about, and there's some good data. There's also a good chance that folks in your own counties and communities have thought this through, because the most important thing is just getting to the first medical facility to diagnose your stroke and to see what kind of a stroke it is. So the short answer is no. And like we learned about from earlier questions, it's really impossible to know if you're having a hemorrhagic or ischemic stroke, even though we understand the statistics. So we want you to get medical care as soon as possible. Usually brain imaging will be done. That will help us determine the type of stroke you had. And then your medical team can determine what types of treatments you might be eligible for, or what might benefit you. And you can get your care initially at a primary stroke center, and that's where most ambulances will take you initially. They'll decide if you need a blood thinner, if you're eligible for one. And then if you need more advanced care, you can always be transferred to a comprehensive stroke center. So I think the take-home message from all of our colleagues today is just get to the nearest medical center and let's diagnose your stroke, figure out what type it is, and see what treatments you may be eligible for as soon as possible. And then Dr. Schwartz also mentioned telemedicine. And as you all well know, in the post-pandemic era, this has become a huge part of stroke care and really overall medical care. I'm sure most people on our call today have done their share of televisits, either provided them or been to them themselves. And this has been studied a lot and is becoming increasingly common for stroke care, where we get stroke specialists to actually provide consultation in communities at community hospitals on specifics of stroke care. And this has also been shown to be a very safe and beneficial way to provide acute stroke treatment recommendations and then triage patients so they get where they need to go.
Thank you so much, Dr. Majowski. I just saw a quick question that came in the chat where somebody was asking, are there any devices or sensors that can alert you if you're having symptoms of stroke, or if you're having a stroke before you have symptoms? And that's a really good question. And it has been we work closely with a lot of engineers here at Stanford, and they've been very interested in this. Particularly, is there a way to detect strokes while people are asleep? And there have actually been some EEG-based devices, and EEG is sort of a brainwave test. And I think I'd say the jury's still out whether things like this are really going to be effective. But probably the most effective thing is just to have you and your loved one know the signs and symptoms of stroke, to be fast, like Dr. Edwardson talked about, and really just trying to get yourself to the hospital as soon as possible. But I'll ask again, to Dr. Edwardson, I mean, is there anything that patients should do at home? I mean, if they're having stroke symptoms, the arm gets weak, their face is droopy, they're having a hard time speaking, should they take an aspirin?
Yeah, the simple answer is no. As Dr. Majalski said, you can't really tell whether you're having the hemorrhagic type of stroke, which happens in about 15% of patients, or the ischemic kind, in which the aspirin might be helpful. But if you do have that hemorrhagic stroke, the problem is that aspirin is going to make your blood thinner. So you're going to hemorrhage even more and maybe turn that moderate stroke into a life-threatening stroke. So yeah, the bottom line is not to do anything in terms of taking any medicine when you're at home. If you feel these symptoms come on, you just want to call 911 right away. Get to the hospital as quickly as possible. Great.
Thanks so much. And I know Dr. Restrepo had said, time is brain. And I guess it begs the question, well, why is that? Or, well, what are you going to do about it? And the short answer is that we, for over 20 years have had treatments available for someone having an acute or a sudden or a new or recent stroke. And so I'll ask Dr. Restrepo again, what are some of the medical treatments that can be given for stroke within those first few hours, and what really is the time window here we're talking about? You're muted there, Lucas.
Sorry. So yes, we do have very good treatments for the ischemic type of stroke. And we do have some treatments for the hemorrhagic type of stroke, but they're not as effective. Now, one of the things that is really very crucial is to figure out quickly if a person is having an ischemic stroke or a hemorrhagic stroke, and that can be done through a quick assessment that includes neuroimages, usually a CAT scan or an MRI. And the CAT scan and MRI look not only at the brain, but also at the circulation of the brain. So if a person has a clot occluding one of the arteries of the brain, the treatment is to open that artery in other words to restore as quickly as possible the circulation to the region of the brain where that circulation has been compromised. And there are different treatments that can be used. The principal treatment, perhaps, is a very clever medication called TPA. The reason why I'm saying clever is because this is a clot-busting medication that exploits actually our own biology. We have in our blood a little molecule called plasminogen. It's a molecule that when after an enzymatic reaction, it starts breaking clots, right? And the TPA is actually able to activate that plasminogen, that normal protein that we have in our blood, causing clots in our body to break up and dissolve. Now, this is very effective, but it becomes more effective the sooner that you inject that medication. Let me explain what I mean. So if for instance, you show up at the emergency department within 30 minutes and the doctor is ready to give you the TPA, the clotting drug, the clot busting medication, you have a very good chance of recovering completely. In other words, that your stroke can be transformed into a TIA, right? In other words, reverse completely the symptoms of stroke. However, if you present 4.5 hours or 5 hours after the onset of symptoms, the effectiveness of this clot-busting medication is really not great. In fact, it's almost the same as not doing anything. As time lapses, using TPA can actually be a little dangerous. So beyond that, what we call a window of treatment, which is usually 4.5 hours, then one could actually cause problems with the clot-busting medication. For instance, in some patients, one can cause bleeding in the brain with that medication. So the idea would be to use the medication as early as possible. And it's not the window doesn't mean the 4.5 hour window doesn't mean that you can sit around, go for a cup of coffee, think whether the TPA is the right thing to do or not. No, what it means is that you have to give the medication as quickly as possible.
Great. Thank you, Dr. Restrepo. So I think the idea is that TPA is a clot-busting drug that can, remove clots from inside the pipes or our blood vessels. And I know at home that sometimes my shower gets clogged up and I pour some Drano in and it doesn't always work. And sometimes I actually have to take a wire hanger or do something sort of mechanical, which brings me to a question I have for Dr. Kay. So what if the TPA doesn't work? What are the other kinds of advanced therapies, maybe analogous to the clogged drain I was just talking about that might be helpful for patients who are suffering from severe strokes? And where can patients get these type of treatments?
Sure. Yep. I want to say the game kind of changed around 2016, 2017 for all the stroke neurologists out there and for patients. There is a treatment that is a big word. It's called endovascular treatment. Endo means within, vascular means blood vessels, and treatment is treatment. These days, just like you were describing, talented physicians can go through your groin or sometimes through your arm and go up your arteries and take a wire right up to the site of stroke. And I'm going to use my pen here. The wire is much, much thinner than the circumference of this pen or the diameter of this pen, but they go right next to where that clot is sitting. And these are for folks who are within the window of getting TPA sometimes and also outside the window, but we all have parameters to be able to do this. So get to the hospital quick. But anyway, once the wire is very close to the site of clot, and the pin is one of the greatest examples of how they do it. As you can see, something will go through that wire, just like the actual pin mechanism here. And this second mechanism, there's several types, will go up there and either corkscrew into the into the clot itself, or sometimes even disturb it with such as a vacuum or something like that. But long story short, it grabs the clot, pulls it within the sheath of the wire itself, and takes it out of the body, and then blood flow is reestablished to that side of the brain, which I think is one of the coolest things, and it's definitely changed my practice once I knew that this mechanism of treatment was safe and proved to be effective. And more data is coming in, and more people are being included to be able to have such treatments.
Great. Well, thanks, Dr. Kay. And yeah, so these treatments are, maybe available for people where the clot busting drugs don't work, or they're not eligible for the clot busting drugs. And maybe can even be used in patients, as 16, 18, 24 hours out. And our center, like many's, may use some special imaging to try to help decide, who might benefit. And so this is usually available at what they call comprehensive stroke centers, but all comprehensive stroke centers have relationships with outlying hospitals, and patients are very frequently transported via ambulance or via helicopter, sometimes after a teleneurology consult like Dr. Majowski was talking about. But the goal is that, every single person in the United States would potentially have access to these type of treatments wherever they are, that they could get themselves to a center with transfer. But having said all that, and having taken care of stroke patients for many years, I could tell you that despite all these really exciting treatments, anybody who's had a stroke would have just preferred they just never had one in the first place. And I think that's really kind of the most important thing, I think, is stroke prevention. And so maybe we'll shift gears here a little bit, and I'll ask, Dr. Edwardson, what are the kinds of what are the risk factors for stroke? And, are any of these things, modifiable? And what can we do in general to prevent stroke, so we don't need TPA, or we don't need the endovascular therapies?
Yeah, thanks, Neil. So there's a couple different classifications, as you said. So there's non-modifiable risk factors, meaning things you can't change, and there's modifiable, meaning you can do something about it. So just go over the non-modifiable first. So that would be things like age. As you know, strokes are more common the older you get. Sex, men are a little bit more susceptible to stroke. And then race. African Americans have about double the risk of stroke than the rest of the population. So those things are not modifiable, but then there are some that you can actually do something about. So these are the modifiable risk factors. They include things like hypertension, hyperlipidemia, or high cholesterol, diabetes, smoking. Another one, atrial fibrillation, inactive lifestyle. So these are all things you can change. I'll just touch on a couple of these that are what I would consider maybe a little bit more important. I mean, honestly, the most important one there is actually smoking. If you're a smoker and you can quit smoking, that is the best thing you can do to prevent strokes by far. Now, outside of that, probably the next biggest thing would be if you have a heart arrhythmia called atrial fibrillation, and most people don't know if they're having one. I mean, you may feel your heart race every once in a while, but there are ways to test for this. You go see a cardiologist. You can get what's called a Holter monitor to look over 14, 21 days, or they can even implant a small device sometimes to test it longer than that. So if you have atrial fibrillation, this is about 5 times the risk of someone in the general population of having a stroke. So that's pretty high. And then just to touch on high blood pressure briefly, they call it the silent killer for a reason. You don't know that you're having any symptoms. You can't feel your blood pressure running high unless it gets astronomically high typically. So you want to get your blood pressure well controlled, below. The guidelines are always changing, but for most stroke patients, I believe it's still less than 140 over 90. They may have lowered it. I know for diabetic patients, I think the goal now is less than 135 over 85, maybe a little bit lower than that even. So
130 over 80, yeah.
Yeah, 130 over 80. Good. So those are the modifiable, non-modifiable risk factors.
Great, thanks so much, Dr. Edwardson. And yeah, I think it can't be overstated how important that is. Doing something like controlling your blood pressure, something like about a 40% relative risk reduction for secondary stroke prevention. But my question then for Dr. Majowski is, well, how do we know why somebody had a stroke? You know, maybe they have some of these risk factors, maybe they have high blood pressure, but how do we know specifically, you know, where does the clot, you know, where did it come from? How do we figure this out? You know, and this is a lot of the work that happens in the hospital, right?
Right. And I'm so glad you brought this up, because I think this is the most fun part of being a stroke neurologist, the most interesting part, and I think also the most important part of providing care to a patient. We have to do a lot of detective work once the stroke is first diagnosed, and this is going to include a lot of different imaging studies, some pictures of your brain, taking pictures of your blood vessels. We also test a lot of labs looking at cholesterol levels, blood sugar levels, and then Dr. Edwardson was talking about the devices that we can use to monitor your heart. And this is a quite routine practice now, where we look for abnormal rhythms such as atrial fibrillation that may increase your risk of stroke. And I know there was a question earlier about devices that we can use to predict stroke. And while we don't really routinely use those in practice, this is a device where we can proactively monitor you for a risk factor that could be significant in your risk of future stroke. So we do routinely use these devices to look at causes. And, you know, for ischemic strokes, we do a bit more workup. We're trying to find out where the blood clot came from or what blood vessel was affected. And it's common for us to treat with antiplatelets, such as aspirin or Plavix, even both of them for a limited time. And this can help prevent additional blood clots from forming. Cholesterol medications are often used. They can help stabilize plaques, prevent debris from breaking off and causing a further stroke. And then also sometimes stronger blood thinners. You may be aware of apixaban or Eliquis, rivaroxaban, Xarelto, or Coumadin from some of the latter years. And those could be indicated, especially if an abnormal rhythm is found. And also, as Dr. Edwardson was mentioning, you know, the prevention plan in hemorrhagic strokes is really focused on the cause. So decreasing the blood pressure, making sure that we have all of the primary prevention taken care of as well. And I also wanted to mention, we were talking early on in the conference about the risk of stroke and the epidemiologic findings with stroke being the 5th leading cause of death. It actually used to be the 3rd leading cause of death back in the 70s. And it wasn't until we really started recognizing blood pressure, cholesterol, and then later in the 90s, atrial fibrillation, and treating all of these things that we were able to see it fall to the 5th cause of death. So all of these things are just hugely impactful in preventing stroke.
Great. Thanks so much, Dr. Majowski. And there's kind of a few questions about aspirin, and I'll sort of open it up to anybody, but I think things have changed a little bit over the years, particularly when it relates to primary prevention of stroke, meaning people who have not had a stroke. And it used to be, you know, in the old days that you'd say, well, every man over the age of 50 should take an aspirin, but that's changed, hasn't it?
Yeah, I can answer that one. You know, my dad had a heart attack when he was 32. Thankfully, he got bypass surgery and survived it. But yeah, so as soon as I turned 40, I think I started taking a baby aspirin every day. But just I think a few years ago, a big study came out, a very large study came out suggesting that this actually wasn't beneficial and increased the risk of bleeding. And so it's no longer recommended for those who have not had any stroke or you don't have risk for cardiovascular disease otherwise. But certainly if you've had a stroke, for secondary prevention, you need to be taking aspirin or something else, depending on what your risk factors are.
Yeah, great.
I'm so glad you mentioned that, Dr. Edwardson. I've seen so many patients in clinic that have come and said, we heard of this study, the aspirin's not beneficial, so I've stopped taking it. But it's important for us to recognize that many of the patients that we see in stroke clinic who have had strokes, who have had heart attacks, really do have an indication to be on this aspirin therapy, and they're not in that primary prevention category.
Yeah, there was just a question about, you know, someone who might be at risk for both hemorrhagic and ischemic stroke. And I would just say it really just depends on the specifics on whether or not aspirin is going to cause more harm than good, and what the cause of the hemorrhagic stroke and the ischemic stroke is. All right. Well, thank you guys. And I wanted to spend kind of the last section talking a little bit about stroke recovery, which I think is really the great frontier of stroke care. You know, we may not be able to treat all strokes, or maybe not everybody will have, you know, a perfect outcome after one of these treatments. We may not be able to prevent all strokes, even with these medications. And so I think really being able to help patients who've had a stroke to recover, I think is so incredibly important. Maybe we can start with Dr. Kay, which is sort of a simple question. You know, what can patients do to maximize their recovery? What do we know actually helps recovery after stroke?
Yeah, you know, I was very lucky in my career that I was given a job once to be the director of a rehab facility. And I've never saw patients recover. If you think about it, I would see patients in the hospital, they would leave and they would be followed up by other neurologists and go to rehab. And I would, you know, my job wouldn't allow me to follow them. But when I was this director of this facility and folks would come down from the hospital and start the process of recovery, my job was to make sure that they didn't have a second stroke. So my salient point here is that the number one thing I'd look out for is not to have your second stroke while you're in recovery. So take the medications, follow the instructions of all the professionals who are weighing in to decrease your suffering and extend your life. Just listen to those folks. However, a little trick that I learned while I was a director, you usually get about 3 to 4 hours of rehab. It's divided between speech therapy, occupational, and physical therapy. And what I would tell the folks after they finish their sessions and they're in rehab, they're doing what they need to, they're listening to everyone, I say, hey, don't stop just because the rehab professional has left. Continue doing what they asked you to do for those 3 hours throughout the day to your best ability, because this window is your best window. The early days after a stroke is the best chances to show signs of recovery. I've never met a person who's had a stroke a year ago and then tell me a month later that they had amazing amounts of recovery. It's something I've never heard of. The folks that have told me they've recovered are within the first 3 months after a stroke. So, you know, the 2 points is, number one, watch out that you're not having a second stroke, because it's the highest chances right then and there. Number two, if you're given instructions during your rehab, remember those, write them down, ask for pamphlets of what you guys did, and try to constantly bombard the brain with those rehab technique and extend that time period of the exercises much more than the 3 hours you get in rehab.
Thanks, Dr. Kay. There was a question came in about vascular dementia, and there is sort of this overlap between kind of cognitive health and vascular health. And I understand that there is a relationship between development of dementia and stroke. And so I'll ask maybe Dr. Restrepo to comment on that, and you know, is there anything we can do about this?
Right. So there's a very complex and rich interaction between stroke and dementia. The dementia means simply having cognitive problems to a point that you need assistance with your activities of daily living. So for instance, a person who was perfectly independent has, with the dementia, with the problems thinking, they now require assistance, say, scheduling appointments with doctors, or setting up transportation, or requiring assistance with financial operations. The reason for this is the most common cause of dementia is Alzheimer's disease, which is a brain illness in which some cells in the brain, for reasons that are not entirely clear, start dying out gradually. And one of the things that hastens this process of brain cell death is having poor circulation in the brain. And the alteration in the circulation of the brain is driven by cardiovascular risk factors. such as hypertension, cholesterol, smoking, etc. And interestingly, hypertension and other cardiovascular risk factors also increase the risk of developing not just dementia or vascular dementia, but Alzheimer's disease per se. Now, the other side of the coin is that when one has a stroke, that stroke increases your risk of developing dementia. In fact, when you look at populations of persons who have sustained a stroke, regardless of the symptoms, about 1 out of 5 develops dementia. In other words, one of the potential consequences of having a stroke is that you may end up with problems thinking to the point that you require assistance with your activities of daily living. What can you do about it? Well, first of all, prevention is paramount. If you were able to consult with your physician, figure out what's your blood pressure, figure out what's your cholesterol, figure out what your blood sugar is, exercise on a regular basis, choose carefully your foods, then you can actually reduce substantially the risk of having a stroke and also reduce the risk of having dementia. One of the best kept secrets in medicine is that by reducing your blood pressure, you are actually able to prevent dementia. You reduce the incidence of dementia in the future. For sure, looking at the usual indicators of health when you go to see a doctor, blood pressure, blood sugar, cholesterol, those are things that, when controlled, can help you prevent a stroke and, more importantly, dementia in the future. Also, when a person has a stroke, you also can have other things that can undermine your cognition. The principal one is probably depression. So depression is a psychiatric illness where a person is unable to enjoy usual things. They feel like they don't have energy to do the things that they enjoyed. And also, you may have difficulties thinking. The problem with stroke is about 1/3 of all patients with stroke, that's 1 out of 3 persons after a stroke, develop depression, and depression can have those cognitive problems. Many of those cognitive problems can improve with treatment of depression. Another thing that can happen to a person with stroke that can undermine their cognition is obstructive sleep apnea. Obstructive sleep apnea is, in essence, a difficulty to bring air down to your lungs when you are sleeping. And when one of the principal symptoms of this is snoring and feeling like the next day you feel like you're not refreshed, like you don't feel like you that you enjoyed a good quality sleep. Interestingly, about 80% of people with stroke have obstructive sleep apnea. And sleep apnea is something that has a very successful treatment. Sometimes you need certain devices to keep the airway open while you're asleep, and that can translate into a better cognitive function after a stroke.
Yeah, thank you so much, Dr. Restrepo, for that. And there was one of the very first questions we got has to do with, can the brain regenerate itself after stroke? And, maybe I'll kind of turn things over to Dr. Edwardson, who I know mentioned in his introduction, has a research interest in stroke recovery. But, what is the time course of recovery after stroke? Dr. Kay had talked a little bit about this, and can the brain regenerate, or what? Is there anything new on the horizon that maybe we could look forward to?
Yeah, that's a great question. So this question of whether the brain regenerates itself, once those neurons are dead, they don't come back, unfortunately. But there's still room for hope in the sense that there's some redundancy baked into the brain, the way we're made. parts of the brain can take over for other parts that have been injured. And so, when I see somebody that comes in with a stroke, I try to look at how much have they lost. If you think about a particular function, so let's say you're talking about arm function. Is the arm completely weak or is it partially weak? If it's partially weak, there's a good chance that there are other parts of the brain that can kind of pick up where the neurons that died have left off, and they can reprogram themselves to a certain extent to take over function. And so if you have a partial loss of some ability, chances are you're going to get a lot back. If you have a complete loss of that function, maybe the limb is completely weak, you're much less likely to get something back. But then in terms of stroke recovery, it varies quite a bit depending on the severity of the stroke. So patients with mild strokes, recovery happens within a matter of weeks. If it's more of a moderate stroke, it's going to happen over a few months. And if it's a severe stroke, it may take 6 months to a year before your recovery has started to plateau. And I just want to address too, what's on the horizon as far as treatments. I know that many of you on the line probably have had your strokes a year or more ago, and I don't want you to be disheartened. It is true what Dr. Kay said. If you are aggressive about therapy early on, that's when you tend to see the most bang for your buck, let's say, and you get the most recovery. However, there are studies showing that even a year out or more, if you continue to do therapy, you can get some gains. And I don't want to mislead you. These gains are not going to be miraculous, but there is some evidence to suggest you may be able to do some activities that you were previously unable to do if you do a significant amount of therapy. So, I encourage you to keep active and continue to engage in some therapy. Now, in terms of some of the studies and in terms of the research that's gone on in stroke recovery, I'm just going to touch on a couple things. One of the things that came out in the last year that was promising was actually, and I'll just start off by saying I have no stock in the company or anything like that, but so there's something called a vagal nerve stimulator. And so it's a little implanted device that stimulates the vagus nerve, which is in the neck, and it causes some modulation of cholinergic neurons in the brain. And if you turn it on when people are undergoing rehab therapy, it's actually shown to be pretty effective, even in patients who are over a year out from their stroke. And I was very skeptical initially, but I went to a conference where I learned about all the, the animal models that led up to the clinical trials, and it actually, I think, is worth considering. So that's something to consider in the chronic phase, meaning more than a year, 6 months after stroke to a year. Now, there are a lot of other things that are out there that you've probably heard of, things like stem cell therapy, things like brain stimulation. And I will just say that those things are still experimental at this stage. None of them have been shown to have clinical efficacy in clinical trials, but it doesn't mean that there's not potential there, particularly with stem cells. And I think Neil might have mentioned at some point to me that he's engaged in some of these studies. So, I would just say that if you are thinking about something like that, meaning brain stimulation, stem cell therapy trial, do it in the context of a clinical trial. Don't go off and try to fly to Mexico to get stem cell therapy, because that's a very bad idea. You're going to end up with bad complications. So that's a little bit about what's on the horizon and what is currently available for recovery.
Yeah. Thank you so much, Dr. Edwardson. And that's really sound advice, and it's certainly advice that we give our patients, that just to be very cautious about things they read on the internet that just are testimonials about this work, or someone who's going to collect money from you for some sort of a recovery treatment. But I do think that there's some pretty exciting things on the horizon, and I think if we give the same conference 10 years from now, we'll be able to really talk about some exciting ways to recover brain circuits. So I see that Robert is here, which probably is our cue, meaning that we're out of time. But I just wow, we covered a lot of ground. We talked about really some of the basics of stroke and the different types of stroke, the signs and symptoms of stroke, the recognition of stroke, how important it is to get emergency care, what are the different treatment options for stroke, whether they're the clot busting drugs or the mechanical treatments that are done in the cath lab. We talked about stroke prevention, and we talked about stroke recovery. And I just really wanted to thank all of you for a really robust discussion, and for all your thoughts and all your really great care that each of you provide for patients. And of course, I'll thank the audience for submitting these really, really great and thoughtful questions, and for everything you're doing to care for yourself and to care for the people you love. Robert?
Dr. Schwartz, on behalf of the Kensington, I would like to thank you and all of our participants this afternoon for taking time out of their incredibly busy schedules and supporting us with this wonderful seminar. The best part about this seminar is that we have part 2 scheduled for July 14th. So all of you who have participated today will be notified by email of our next seminar. Thank you.
Thank you all. Goodbye, everybody.
Bye.
Thank you.
Thank you.
Thank
Goodbye.
you.